I was able to go through the process with them, get them seeing again, and then within a couple of weeks see their life completely change, almost completely non-functional to now being able to support their kids. Being able to see that reward really inspired me for that community clinic setting to kind of make that life-changing type of experience.
Yaz and Chan, my friends and colleagues. I'm your host, Dr. Joseph Allen, and welcome to the I Give a Damn podcast, brought to you by Fluorescene Media, the same company behind Odie's on Facebook. Before we dive into the episode, I do want to give a big shout out to our sponsor, MacuHealth. If you've been following my content, then you know how deeply passionate I am about ocular health, as well as improving and protecting the eyesight of our patients in the clinic. MacuHealth is known for their triple carotenoid formula, lutein, zeaxanthin, and mesozeaxanthin. And whether you're concerned about age-related macular degeneration or just want to help your patients with the nutrients they need to stay sharp, MacuHealth has you covered. We'll talk about MacuHealth again a little bit later in the episode, but otherwise, let's get going. Today, our special guest is Dr. Andrew Kemp, who is the AOA's 2022 recipient of the Optometric Educator of the Year Award. And in today's episode, we discuss not only his experience teaching and providing mentorship to students, but primarily serving in a community-based eye care clinic. I think if you are somebody who has a passion for serving your local community and those in need, as well as passing down your knowledge in the form of mentorship, this is going to be an amazing episode. Please join us by hitting those subscribe and like buttons, and here we go with Dr. Andrew Kemp.
Yeah, named Andrew Kemp, and I'm a clinical assistant professor through the University of Houston, but I work at an external clinic in the Dallas-Fort Worth area. So we have student externs that rotate through us, so I see patients alongside them, kind of give them that hands-on kind of clinical education, teach them in a more clinical setting. We do some didactic information, but a lot of clinical education with the students in both our Dallas clinic, and then we have a sister clinic in Fort Worth. We also have 2 ocular disease residencies that we kind of work with and educate that way too. So got some pretty good-sized things going on, yeah.
So tell me, how did you end up in your journey working in a community clinic? Because that's kind of unique in a way.
Yeah, so the clinic I work at is also a rotation site for students. So I went to the University of Houston as a student as well and rotated through this clinic. And then I knew I had heard good things about the clinic as a student, but I didn't really know what it was really all about. And then I got there, and it was a really good combination of both student education and then the ability to provide care to patients who didn't really need it. And I grew up in a relatively middle-class neighborhood as a kid, and I felt like I had access to a lot of things, so it kind of opened my eyes up to that kind of world of people who didn't have that same type of access, and I felt really privileged to be able to be part of a system that was able to do that. And then the atmosphere that the faculty that had created as a student was really interesting, and I really kind of flourished in that because it was a lot of encouraging students to ask questions. There had been, I know we've all probably had experiences as student doctors in terms of like, well, I don't feel like I kind of understand this, but I'm not really sure, but I kind of need to ask a question, but then I also don't want to feel like I portray that I don't know what I'm doing, so then you may hold on to a question or two like that for a really long time, then you graduate and then you realize I actually don't really understand this, I should have asked that question. But this clinic really created that environment to feel comfortable to say like, hey, I think I know it's this, but I don't really know that whole thing, so it really was able to kind of build my confidence there, feel like I could ask those questions and then take it down to clinic, and then be able to provide that care to people who didn't previously have access to that. So that really inspired me as a student, inspired me to do my residency at the same clinic, and then when I had an opportunity to come on as faculty, I was really honored to be able to have that opportunity.
So just from hearing that from you, it kind of sounds like you maybe don't cast as a teacher, as a teaching institution, you yourself maybe don't cast that like bad cop, like I'm going to just make you feel super stupid sort of thing on your externs. You're probably a lot more encouraging, like let's work on this together type of thing.
Yeah, and what we really try to do is we try to make students go through the process of making the decision even if they end up being wrong about it, because we're right in that transition from third into fourth year, so we all work with fourth year students, so they've had all the didactic lectures, but they just haven't had the process of making that clinical integration and making that decision. So we really strive to, even on the first day, if they're going to make a diagnosis of glaucoma, even if I feel like they may be heading down the wrong direction, I kind of let them finish the thought process. I was like, okay, well, if this is what you're going to diagnose, then how would you treat it? When would you see them again? And then once they are able to make that, I don't know, experience going through the whole process, even if it turns out, I was like, well, this is where I thought maybe you went down the wrong path, and let's look at what you did, and this is actually what I would do, even since they were wrong, but they went through the process, and then the next time they can feel like they already have that structure to follow and just make slight adjustments throughout the whole semester that they're with us.
Yeah, they're definitely putting in the motions of, I think of it like swimming, for example, like they're actually learning the stroke. They may be going the wrong direction, they might be doing it perfectly, but then it's like, okay, well, you did good for that, but let's take a look at this one thing that I think you might have missed.
Yeah, and I think it makes them more open then to other situations to expose maybe some of their weaknesses and things like that and learn going forward.
Cool. Did you ever have that experience as a student where one doctor maybe taught a little bit more in your style, the way that you were more receptive to, or did you ever have a kind of one of those other doctors who maybe just made you feel like crap because you didn't know something?
Yeah, I mean, there's always different experiences, and I don't really think that any educator out there intends to do that, but we all have some styles in terms of like some people need to have that additional stress to kind of push them forward. So I had a variety of experiences for sure, and then what was inspired me to come back to this Dallas clinic is because of those faculty members that I learned under, they really provided that comfortable environment for me. So they inspired me to be who I wanted to be, and then with the opportunity to join them, I had to jump on it.
That's great. So how did you know that ultimately you wanted to work in a community clinic and that you wanted to more or less be a teacher and be that such an integrated part of what you do?
Yeah, so I think with the indigent care type of community clinic setting, I think it was just really unique to be able to see how much impact we could make. So our clinics also make, or we work with a lot of even especially contact lenses. So we work with some companies to through the kindness of their heart, the companies have been able to donate some of these scleral lens fits and things like that. And I've had some opportunities where people just couldn't work, they didn't have jobs, they didn't have an income to reach out and do anything, and a lot of it was because of their vision that they weren't able to do any of that. So then I was able to go through the process with them, get them seeing again, and then within a couple of weeks see their life completely change. So they went from almost completely non-functional to now being able to support their kids and all this other kind of thing. So being able to see that reward, I was able to provide that for these people that wouldn't have access to it otherwise, really inspired me for that community clinic setting to kind of make that life-changing type of experience. And then during my residency is really when I became familiar with teaching, because that residency really inspires you to be an attending along with direct patient care and seeing that kind of same clinical integration that I saw in myself as a student, that kind of like aha moment in terms of like, oh, that's what it means. So like just being able to see that kind of like moment of like connection and then almost release of stress, because now the student really understands it. That just really kind of felt good to kind of see and be able to keep doing.
Now, in these community clinics, you're seeing oftentimes a lot of people who are less fortunate. They don't have access to care. Maybe funding is a big issue. I imagine you see a lot of disease in that as well.
Yeah, so lots of disease, and it's kind of an unfortunate combination in terms of there's a lot of people who their first healthcare appointment in their entire life is when they're 60 and they see us. So it's like they don't really understand any real medicine in general, so then we have to kind of explain the whole system on where we can go and how to take care of everything, not just the eyes. So yeah, we see all sorts of different things, and sometimes in more advanced type of cases because they haven't had access to it. So it's definitely intriguing for me as a career in terms of it keeps me on my toes, and then these people often benefit the most because they just haven't had access to it.
I imagine the disease, if they had something, it's been ongoing, unchecked, for years and years and years. It's almost like doing a mission trip in like the Dallas Fort Worth area.
For sure, yeah, and I think it's kind of unique too, because we've been able to build a pretty good community. So we have like surgeons that often donate their time for us, and then other specialties, and then communicating with them and how much they really like to enjoy it because of the advanced nature, and it keeps them on their toes. But yeah, it's like some of these cataracts walk in and they come in and they see hand motion in both eyes, and it's just like you wonder like how they've been able to navigate life in general. It's just it's unfortunate, but then again, kind of feels good to be able to be that person that's able to kind of get them to where they need to go.
Sounds like you guys are delivering some excellent care. You're obviously you're having a lot of achievements helping patients, also helping students, and helping excel in those regards. Do you have anything working in that environment that you find really is frustrating, that you feel limited by, or you wish you could fix, or something you've been working on?
Yeah, I mean, it's probably something that everyone as optometrists kind of experience in terms of like the limitations of different insurances, and even some people who have insurance may not understand the plan, and the one that they signed up for is actually really doesn't cover a whole lot, or they may be paying $100 or $200 a month to think that they are doing the right thing to have insurance, and then they didn't realize that when you look at the provider panel, and no one in 100 miles actually takes the insurance to be able to do anything with it. So, and then sometimes even the kind of assistant plans from charity groups and whatnot, if you have insurance, you don't qualify for it. So then they're stuck in this, they're trying to do what's right and buy into the system so they have support, but then there's no support there, and then they disqualify from other things. Or we're lucky that we live in Dallas County, and we have a pretty robust county hospital system, but we don't have any type of restrictions at our clinic, so we'll often get people outside of the county, and then they don't have that same type of fail-safe system if they're in the more rural areas. So it really kind of limits what you can do, so it can be difficult to navigate where they go.
I want to take a quick break just to remind you about today's sponsor, MacuHealth. If you are listening to this, then you probably care about eye health just as much as I do. MacuHealth offers a line of incredible supplements that's formulated around published science. MacuHealth is known for featuring the 3 most important carotenoids for your macula: lutein, zeaxanthin, and mesozeaxanthin. Whether you're managing age-related macular degeneration or simply looking to offer your patients a high-quality supplement you can trust, MacuHealth has your back. Now, back to the episode. For our listeners, before we started recording the podcast, you were mentioning, Andrew, that there's times when you have extra challenges like time constraints, like somebody might be in the country for only so long.
Yeah, so I mean, depending on what their travel visa limitations are and things like that, or they may be visiting family for a couple of months and they didn't have access to wherever they're coming from, and they come in and they have cataracts. So then we need to figure out not only where are they going to have it done, but then in what time frame to make sure that they can stay for the postoperative care. Or we've even had to communicate with providers in other countries who are in the following up care, especially with chronic diseases that are going to need ongoing care. Then we've actually had to figure out, well, give them my email, and then whenever you see them, let me know, and we can kind of communicate. So we've even been able to kind of connect internationally with different people.
Wow. Do you get a lot of patients who are like lost to follow-up because of that?
Yeah, always. We definitely do. I mean, whether they're visiting here or even if they're local, just in terms of like sometimes people are just moving from family member to family member, so they may be staying with the cousins in Dallas now, but then may have to go to another state elsewhere. So yeah, there's always going to be kind of lost to follow-up, or we see people come in from rural areas that are 4 or 5 hours to drive to come and see us, so they can only do that so much. So there are lots of limitations that way as well.
Now, how big is this clinic that you're working at? Because you have a lot of students, quite a few, right? Are you seeing patients from start to finish yourself, or are you just managing all the patients that the students are seeing at the same time?
Yeah, so I mean, we have 11 students at the Dallas clinic. 8 of them are actively seeing patients, and 3 of them that we kind of have them doing kind of hands-on work, like the pre-workup, and then we have all the special testing, OCTs, B-scans, and things like that. So as they're needed, the students are getting the hands-on experience to be able to not only interpret these tests, but then understand like how difficult can it be to get an OCT on an eye that they can't see very well, or things like that. So they get that experience. So we'll have 8 students and then the resident, and they are anywhere from 50 to 80 or 90 patients a day. And then I have other faculty members that are with me at the clinic. So they'll often kind of get started with the students, and then I'll come in at the end and kind of finish up with the patient with them to make sure that we're all on the same page and doing everything that's best for them.
That's an impressive operation. You mentioned you guys have some specialty like contact lenses and things that you're fitting. Do you guys have any other type of specialty care, things that you offer?
In-house, it's kind of still mostly going to be, I mean, we can handle any type of ocular disease because of some of the relationships that we've made with companies that have been able to either donate equipment or provide it at a reasonable or a lower cost for us, especially contact lenses for sure. But if we don't have it in-house, we've been able to more or less connect with different foundations. So we have surgical foundations for cataract surgeries, glaucoma surgeries. We have partners in the area that know that patients that come from our clinic for even vision therapy or something like that, they can work on their payment plans or discounted costs because they know we've been able to build up a good relationship with the community. And since we have so many students, a lot of them end up in the area. So if they enjoyed their experience with us as a student, then they are more willing to kind of extend their specialty for their low-income patients that come from us.
How about yourself? Do you have a certain disease or thing that you just love managing or nerd out on if you dig into the research?
Yeah, I mean, I'd probably say like my specific niche in terms of both seeing patients and then kind of lecturing on has really kind of dove into like glaucoma care is one. And then I'm one of the faculty leads on the medically necessary and specialty contact lenses as well. And then I've kind of one of my mentors at the clinic was also big into like billing and coding as well. So he's kind of pulled me into the billing and coding compliance world. So I've been able to kind of pass along some of that education to the students as well.
I imagine, you've had to learn a lot of ins and outs with the billing and coding because of how that works with your clientele, for the type of patients that might be coming in, if they have insurance from a different location, if they have the current insurance there or none.
Yeah, I mean, it can be tricky. I mean, some of our patients are cash pay, and that makes it easier. But then we often are one of the sole providers for a lot of the Medicaid plans in the area, and then it can be tricky just because like Medicaid plans in Dallas aren't always the same as Medicaid plans in Fort Worth, and the way you bill them are differently, and then those plans are constantly changing as well, and the code that you use for the medical plan may be different than whatever wellness component that they have in there, and then the patients themselves don't really know what their coverage is, so we have to end up looking that up, and in order to kind of keep costs down at the income clinics as well. Me and some of the faculty often tend to be some of those that look up the benefits and figure out where they can go and that kind of stuff. So we've kind of been forced to dive into that world as well, and it can be confusing, whether it's intentionally confusing or not. It can be confusing and constantly changing.
And I imagine most of the students at that point, they have no idea, maybe barely. They know that there's maybe sometimes there's this thing called an S code versus the 9 codes, but they probably don't know much.
Yeah. So one of my first lectures that I give them as soon as the students come up is what is a 92 code, difference from an S code, when can you bill a 92 medically versus a 99 medically, and when you should do that. Really getting into the basics for it, not only just in billing and coding, but even in medicine, because a lot of them haven't even had to deal with like insurance on their own, so they don't even know like what is a deductible. A lot of students don't even know what a deductible is. So then whenever you're considering like, well, I'm going to order this test for this patient, was like, okay, you need to do what's medically necessary for them, but there are some considerations in terms of if they haven't met their deductible, then they're going to get a bill after that, and it's always good to make sure that the patient understands what's going to happen.
Especially in a special population like that. I think it's everybody no matter what, but it maybe some of the populations that you're seeing in a community clinic may be at that may be a bigger risk factor for them, right? It's like suddenly they can't maybe afford housing or food or something. There's probably tighter budgets in that regard. Yeah,
that's often what's limited them from being able to access care before, is because the initial cost of even seeing somebody through their insurance or something like that it just was too overwhelming. Yeah. So then we can fall back on some kind of scaled payment plans and things like that to kind of help out, kind of ease the burden and whatnot.
Being that you see so many students, in your experience, what's kind of some of the common themes that students are slow on or maybe behind on, maybe haven't just been exposed to?
Yeah, I mean, I think the biggest area that all students grow is just kind of that ability to think as a doctor. A lot of their initial education and whatnot is all about what are the facts that I need to memorize, what tests are even out there, maybe how to run them, but in terms of like integrating it into a particular condition, in terms of when would I order this, when is it necessary, and then really creating the whole management plan is at least the biggest area of growth, but that should be natural kind of as a fourth year student. But always kind of that critical thinking in terms of a clinical setting is where we see the biggest growth.
How about with residency? You said you have at least, one resident, 2 residents?
Yeah, we have 1 resident at our Dallas clinic and 1 in the Fort Worth clinic. And I think a lot of them are actually students that rotate through, and then they see how much value there is and they want to stay with it. And we really kind of push our residents into not only direct patient care themselves, but also we get them into the kind of attending clinical faculty role relatively early, because it really helps them build their differential diagnosis and the ability to build that list. And then the students really keep you on your toes as well, because once you get them encouraged to ask questions, those questions really start to challenge even your own knowledge in terms of like when they start asking why, it's like, well, why does this condition do that? And then it's like, well, if you don't really understand the condition yourself, it's hard to answer that question. So they can actually continually expose even my own kind of gaps in knowledge and to keep me pushing forward. So it always keeps me learning myself, especially with even as new technologies and things like that come out.
I remember when I went through residency and some of the challenges that I had, right? You go in thinking, oh, I did well in school, I did well on my boards, and then you're like, whoa, okay, I'm being challenged to like 100th degree. There's those tough moments. But then one of the fastest areas of growth for myself, I remember, was when I was moonlighting outside of the VA system where I did my residency. And it's like, oh, okay, I know what I want to prescribe. But I'm like, how do I actually do this? Like, do I have a prescription pad paper? I have to write it down, and that's ultimately what I had to do in that situation. Like, or how do I order this? Because I knew how to do it at the VA, but I'm like, okay, and there's no one above me. There's no one for me to call. I have that moment. I have to be the doctor and make that decision and move forward. And I think that's a memory of just me, like, okay, I am a doctor now. I have to do this. And do you ever see those moments in students and residents?
Yeah, and I think, you can't really have that true moment until you're truly alone, but you can definitely, at the beginning of the semester, often people often call it the deer in the headlights look. They come in and they just they put the paper down. It's like, I don't know what's going on. And then so it's like, that's how it starts. And then by the end, they're coming at least with the full kind of, well, this is what I'm seeing, this is what my differential is. And even if they're not sure what it is, they've at least gotten to the point where they know how to build a critical thinking list and kind of figure it out. So I feel much more confident that when they get put into a situation, they can think critically and figure it out. Because I remember even as a student, I'd often memorize diabetic retinopathy, here's the picture, photo 2A from ETRS, this is what I memorized. So if it looks exactly like this in the picture, I'm going to get it perfectly 100% every time. But we all know that diseases present extraordinarily differently in every single different patient. So you can't rely on just the memorization of those isolated images. You have to really think about it on a core concept level so you can apply it going forward. And that's kind of where we really see that growth, and especially on the resident side, being able to approach situations that you haven't been put in before and still be able to approach those complicated situations and know what to do and figure it out on your own is kind of where the difference between student and resident, for sure.
Do you guys also do journal clubs? Do you have, I don't know if you give out homework, assignments, have students give lectures or kind of grand rounds? How do you guys do that?
Yeah, so with the resident, we definitely do journal clubs every month in terms of we each take turns kind of picking a journal to kind of talk about resident and faculty and things like that, so we don't get just stuck in our own specific niches. We can kind of get exposed to what other people are excited about, because you never know what you might find interesting, so we kind of pass that along. And then we always encourage education in terms of continuing education outside of the clinic. And then we do sometimes the students will do different presentations on conditions that they feel most interested in. And then the resident will do a lecture as well in terms of a particular area that they felt interested in. Like my residency exposed me to kind of ultrasound on a high amount for the first time. So then I didn't feel like I understood it as much. So then
AB scans.
Yeah. So I had heard of it in school, but it just didn't have as much exposure to it. And then we see a lot of pathology that you can't see into the eye. So we use ultrasound all the time,
sort of
massive cataracts or vitreous hemorrhages, and or you have referrals, and it's like, well, is this a tear or a detachment? And the way that we manage it is completely different. It's either a couple $100 visit at a retina specialist, or you're talking about $3,000, $4,000, $6,000 for more invasive vitrectomy surgery. And how we manage this and who we need to approach is completely different. So I can't rely on, I have to know what the difference is, and the ultrasounds have really made it to we can make much more efficient referrals and not kind of waste resources.
And so you guys have a B scan in your clinic.
Yeah.
That's cool. That's good to have access. I think that's one of the tools I think a lot of clinics don't maybe have access to.
Mm-hmm. I think, it changes a lot of what I do in terms of not only advanced cataracts, but anything in the vitreous. It's much easier to image that way. So my first exposure in large amounts was that during my residency. So that it challenged me to do a presentation on it, and I feel much more comfortable. And now I use it way more. So the more you understand a concept, the more likely you are to do it. And so we challenge the residents to kind of pick what they feel less comfortable with, and I think that's a big strength. I think that's just a talent that everybody can benefit from in terms of it's hard to recognize where you're weak in and then be able to build something to make it kind of fill in the gaps.
Always being a student, right? It's really important. The being in a community clinic, I imagine, you see a lot of disease. Do you see a lot of diabetes? Do you see, is it mainly older folks who are, got really extreme cataracts, or do you see just a plethora of everything?
We'll see everything. I mean, we don't have any restrictions in terms of age, so we'll see infants and kids. Okay. We'll try to do our best in terms of when it comes to whatever amblyopia and BV therapy that we can, and then get it to more specialists that when it gets kind of outside of where we feel comfortable with. So we'll see kids, we'll see wellness exams, and then we'll see all sorts of advanced disease. So it keeps all the students on their toes and whatnot. I'd say diabetic retinopathy and glaucoma are probably the biggest ones, but then we do get unique kind of uveitis cases. A lot of these patients don't have their own kind of PCP set up, so then we've had to get into our own type of ordering serology. We order our own MRIs and things like that when it's necessary. Again, because we don't have easy access to affordable neurology for discounted consultations, so we need to kind of get some of the steps done before we get there to, again, try to optimize resources and things like that.
Cool. Well, I know you've been doing this really cool stuff with community. You teach quite a bit. Do you ever get overwhelmed with it? Do you feel like you manage it pretty well, like leaving work at work, or do you?
Yeah, I mean, I think I do relatively well. There's always going to be a case or two. I think this happens to everybody, no matter where you are, in terms of like, especially with low income, just like their one eye's already gone. You're watching their one good eye kind of, it's on its way out, and what can you do? And then you're worried about, are they going to be able to follow through? Who can I get them to? All that kind of stuff. So that will always that'd stress anybody out for sure.
I've lost sleepover cases like that.
It's like that happens no matter communicating or not. So the same kind of thing. I think some of the rewarding cases kind of help balance the emotions on that. But there's always a challenge, especially with the social work side of it. Of like, not only is like, well, I know what needs to happen, but now it's the logistics of how does that even happen, is always kind of sometimes the most stressful part.
Right. I love that you mentioned the social work component, because that is really going above and beyond sometimes. I think as optometrists, we're so narrow focused on eyes, that we can forget like our patients are going through a lot more in their life. They may not have access to things. They may not even know how to get access to something. Mm-hmm. And that's just a big challenge, I think, in our healthcare system, period, now.
Yeah, and I think it can be draining on offices in terms of time and things like that. And often see a lot of people who they may even already know what the problem is, but they said, like, I saw this eye care provider or this PCP for this condition 3 years ago. They told me what it was, and then they never followed up, or like they scheduled a follow-up and they weren't able to make it, but then there was no follow-through on it, or they said that they needed to have this particular surgery, but then they left it up to the patient to figure out how to get said surgery done, and they didn't know what to do, so then it just kind of passed on. Or they sat in the emergency room for 24 hours and never got seen, so then they left, and then they're just stuck with whatever they have. So it's just that extra step or two, or like sometimes it's sitting on a phone on hold for 4 hours waiting for an insurance company to get through to you, those extra things that it just takes to kind of get through.
Well, clearly you have a passion for not only helping people, but for this, in many ways, community service. How did you even find optometry in the first place?
Yeah, I don't really have like a huge origin story. It was actually kind of my best friend's mom's idea. She really enjoyed her optometrist, thought that she was doing good things for the community there, and she kind of convinced me to look into it. And then the more and more I got into optometry, I really liked it, and I was even kind of going, like a lot of us, going through like the pre-med or pre-optometry type of thing in undergraduate, and then a lot of the pre-med kind of the groups that I joined and people I talked with, it was a lot of it was a lot of competition in terms of like, how can I beat this other students to then get into medical school? And then I went and talked with all the optometry students, and everybody there was very welcoming, and it was kind of much more of like a, how do we all get into optometry school kind of feel. Okay. So it was just kind of like that warm community that kind of I bonded with when it came with optometry, and then it kind of flourished as I went through.
Well, I'm happy that you had that experience, because you've been a great leader, I think, in our profession in terms of teaching, in terms of who you serve. So that's great.
Yeah.
With my podcast here, I love asking this question at the end, but it gives a good idea of like what really some of your core values are with optometry. But if you were elected tomorrow as kind of the Surgeon General of optometry, you were elected to this high level of like, hey, we want you to lead the entire profession of optometry, what would be your main goal for your election? What kind of change would you like to see in optometry as a field, or in our ability to help serve other people, like a public health effort? What do you think would be the biggest change you'd like to see?
Yeah, I mean, I think things are already moving in kind of the right direction for optometry in terms of, I think, what we're trained for. A lot of optometrists across the country aren't able to practice to the kind of the fullest of their training. So of course, getting to that point, I think will be huge. I mean, I think we all acknowledge, and there's a report on optometry and ophthalmology, and in terms of public health, just like the potential lack of access to care going forward. And I think optometry is poised to be able to fill a large portion of that gap. And I think that's not only just physically being where the care is, so making sure that we can fulfill those rural kind of clinics, or making sure that people practice to the fullest extent. And I think a lot of that even it starts with how we value ourselves as optometrists as well, because like I think that's where it starts really, is like, well, we are the primary eye care providers. I think we are what patients should rely on in terms of when it comes to like, anything from contact glasses, or if I have a particular condition and I want to be able to talk about what are my best treatment options, I think the optometrist is best poised to be able to have those conversations and then handle what's they feel comfortable with. And if it needs to get somewhere else, then I really think that the optometrist is really kind of that core kind of person that can be there. And I think a lot of that starts with our own perception of what optometry should be and where we should be.
And I agree with that. That's something I think we all have our analogies of how we describe that to a patient. I sort of describe it as, well, go see your family doctor, your primary care provider. They'll take care of diabetes. If you have a heart condition, high blood pressure, they'll manage that. But if you need cardiac surgery, they're not going to be doing that. They're going to send you to a specialist who just does cardiac surgery. And I think of that kind of how my role is, because I've seen my family doctor and asked them, hey, what's this, spot on my leg that's growing? Is this a mole? They're like, oh yeah, well, I can just take that off right now if you wish. I didn't have to go see a specialist to deal with it. They were able to do it. And I think, like, no, we have we have that training, the skill set. These are things that we need to do, especially if we don't need to go into an OR.
Yeah, and I think that will really help with access to care, and I think that will also I think make everybody feel really invested in their own careers and help prevent some burnout that some people may feel and things like that too, because the more that you're able to provide for your patients, the more rewarded that you feel, the more rewarded they are, and all that.
Well, Andrew, thank you so much for being a guest here on the podcast. I'm really happy that we have such an excellent educator, leader like yourself in our profession.
I appreciate it, and yeah, it was a pleasure to be here. Thank you for having me out here.
So that was our episode for today. Thank you so much for tuning in. Please do us a favor. If you are finding value in these episodes and you have not subscribed to the I Give a Damn podcast over on YouTube yet, then please do so, because that will help us grow this channel, this podcast, and help us reach more people. In addition, if you know of a guest, you think somebody in the eye care profession that's an entrepreneur, a leader, an expert of any form, and you think they would make an amazing guest here, please suggest them either by dropping us a comment if you're watching this on YouTube, or leave us a review on whichever podcasting platform that you typically download your podcasts from. Otherwise, again, Dr. Joseph Allen here. Thank you so much for joining us, and I hope you have a fantastic